Start. Bismillahirrahmanirrahim. My dear students of 4th year MBBS, today our topic of discussion is surgical diseases of the eyelid, that is Entropion and Ectropion. As seen in this slide number 1, I am Professor Dr. Abdul Majeed, Head of Department of Ophthalmology of Akhtar Saeed Medical and Dental College. In the previous lecture, we had discussed briefly the inflammatory disorders of the eyelids, like various types of blepharitis, stye, chalazion, and viral lid infections. Today the topics are mainly surgical in nature, that is Entropion and Ectropion. Now, before going to the detail of discussion, we should know the learning objectives of today. Basically, we have to be able to differentiate between irregular lid disorders like Entropion and Ectropion. You should be able to identify them on the basis of clinical presentation of the patient. Patient will not come up with the diagnosis. They will come up with presentation like symptoms and signs from which you will be able to diagnose. If you know the basics of the disease, you will be able to diagnose whether it is Entropion or Ectropion or any other lid abnormality. Having properly diagnosed, you should be able to order the relevant investigations to confirm the diagnosis and further management plan of the patient. You should be knowing brief treatment. You are not required to know the details of surgery, but you should know what are the surgical procedures to be done, and if there is problem in understanding of the patient's disease, you will be able to refer the patient to the ophthalmologist with your proper endorsed clinical notes of the patient. Now, what is Entropion? Entropion is defined as inversion or enrolling of the eyelid margin. What happens that the lid margin that is normally snugly fit with the bulbar cavitava at its posterior margin, because of some pathologies we are going to discuss in the coming session, the lid margin gets inverted. As it gets inverted, the eyelashes start rubbing against the conjunctiva and cornea, and they cause irritation, itching, watering, and pain and recurrent redness of the conjunctiva, and sometimes corneal epithelial abrasions, which may lead to ulceration and opacity in due course. So that is the way patient presents. Patients come with a history of itching, burning, irritation in the eye, sometimes pain, and sometimes visual blurring as a result. For the purpose of description and management, these are divided into various types. Entropion may be congenital, that is, the child is born with the disease, or it may be acquired. Acquired is further of various types: senile Ectropion, cicatricial Ectropion, spastic Ectropion, and mechanical Entropion. By far, the senile Entropion is the commonest variety. Now, in the next slide, I will briefly review the pathophysiology of senile Entropion versus senile Ectropion development. Senile entropion develops due to degeneration of the fibrous tissue separating pre-tarsal and pre-septal parts of orbicularis oculi muscle. See in the next slide. Now on the left part of this picture, I have shown you the anatomy of the eyelids after removing the skin from it. Underneath you are seeing the orbicularis oculi muscle, the one nearest to the lid margin. In front of tarsal plate is pre-tarsal. A bit away, above or in front of orbital septum is pre-septal, and then the orbital portion is far away. What happens in senile entropion, that is entropion age-related one, that appears in people beyond 65 to 70 years of age? What happens that they come to you with history that as they get up in the morning, or if they squeeze the eye, once they open, the lower lid remains inverted and eyelashes keep rubbing on the conjunctiva and cornea, causing pain, irritation when watering, etc., etc. What is pathophysiology? Vertical eyelid stability and horizontal stability is maintained by help of tarsal plate and its overlying orbicularis oculi muscle, as well as by the lower lid retractors. They arise from the insertion of the inferior rectus muscle and they are attached to the tarsal plate of the lower eyelid. They keep the lid stretched and vertically stable. As the age advances, two things happen. Keep in your mind, it is involvement of the lower eyelid. Senile entropion involves the lower eyelid. What happens that the two portions of the orbicularis muscle, that is pre-septal and pre-tarsal, they are separated from one another by fibrous tissue layer. This layer gets degenerated. As a result, the contracting portion of the pre-septal orbicularis oculi muscle slides over the pre-tarsal muscle, as you see in the diagram on your left side, on your right side. Second thing, as this happens, you are seeing in the right side of the picture, the muscle is overriding. Pre-septal muscle overrides the pre-tarsal muscle on lid closure due to weakening of the fibrous tissue between the two. At the same time, you are seeing the red line underneath, that is the extension of the aponeurosis of inferior rectus insertion that contains muscular fibers and that is attached to the lower portion of the tarsal plate. Now, with first change, that is overriding of the pre-septal or pre-tarsal muscle and inversion, the direction of pull of this retractor changes, and instead of changing the tarsal plate pulling it inferiorly, they start pulling it anteriorly. So it further adds to the inversion. So these two pathological phenomena come in action, that is overriding of the pre-septal muscle by on pre-tarsal muscle. I mean overriding of pre-septal over pre-tarsal muscle and misdirection of the pull of aponeurosis or lower lid retractors. Both of these pull the lid margin inward and causing entropion of the lower eyelid. Now in the next picture I have shown you, this is the actual picture of the patients from our department. In the left of the two pictures you are seeing lower lid margin becomes thick. This is the clinical situation patient presents. Patient complains that when they get up in the morning or when I squeeze my eye and after opening the eye, my lower lid remains inverted and eyelashes keep rubbing against the conjunctiva. as seen in this picture. You see the lower lid is thickened as well. Why it is thickened? Because it contains two muscles, pre-tarsal and pre-septal overriding it. So thickness of the lid increases. This is a sign of your interest. You can diagnose just because of thickening of the lower lid. And secondly, you are seeing lower lid margin is inverted and the eyelashes are rubbing against the conjunctiva. On the right side of the picture, eyelashes can be seen rubbing against the cornea. These rubbing eyelashes cause irritation, vaulting and pricking sensation and foreign body sensation in the eye, and if persist for a long time they cause ulceration and opacities in the lower part of the cornea. An interesting mechanism appears when the same aged patient develops senile ectropion or eversion of the eyelid instead of inversion. Why I have placed this picture here? Because the mechanism resembles that of senile entropion but in some reverse fashion. This is the picture you are seeing. There is lower lid is lax and bulging a bit forward, and fluid is accumulating between lower eyelid and the palpebral as well as bulbar conjunctiva that is stained with fluorescence. So again back to the previous picture. Picture of pathophysiology of senile entropion. Here in this patient what happens? Not only the fibrous tissue between the two parts of the orbicularis oculi muscle, that is pre-tarsal and pre-septal, weakens, but entirely there is a degeneration of the orbicularis oculi muscle itself. As a result, total vertical stability of the lid decreases as well as horizontal lid stability. Horizontal lid stability is maintained by orbicularis muscle and vertical by the lower lid retractors I had mentioned here in this picture. The red muscle extended from the aponeurosis of the inferior rectus. So both of these muscles, this aponeurosis as well as orbicularis oculi muscle, get weak, and as a result vertical as well as horizontal lid stability suffers and the eye becomes, or eyelid margin becomes everted as seen in this picture of senile ectropion here. So the difference between the mechanism of the development of senile entropion and senile ectropion is that in senile entropion the muscle remains healthy, but the dorsal tissue and fibrous tissue between the two muscles, that is pre-tarsal and pre-septal, becomes weak, and the pre-septal muscle overrides or slips over the pre-tarsal muscle. Whereas in senile ectropion, entire muscle degenerates and the two parts are not firm or active enough to override one another. So the lid relaxes and gets bulging outwards. That is senile ectropion. Now, there are other types of senile ectropion as well. We will be discussing step by step. So, how to treat this senile entropion? See this slide. First, we should know the instrument used in the treatment of senile entropion. This is entropion clamp or lid clamp. Remember this picture of the instrument. This will be shown to you in OSPI as well. On the right side of the picture, you are seeing two of the instruments, that is lid retractors. They are separate for right and left eye. While using it in Entropion surgery as well as Ectropion surgery, the tough or complete part of the sheet, metallic sheet, is placed on the inward side, that is toward conjunctiva side, and the open side is placed externally. So that once we make an incision from the outside, that incision will not go beyond the lid to the eyeball. What is the purpose of this instrument? It holds the lid portion to be operated strongly, provides an excellent hemostasis, that is no bleeding during surgery. It protects underlying conjunctiva and other eyelid structures, eye structures. And that should be remembered by you. This is Entropion clamp or lid clamp. Now this is the surgical treatment of senile entropion we have discussed. We have to reverse the mechanism that led to development of senile entropion. So from left to right side there are procedures. Left side, transfer lid everting suture. This is a temporary measure as seen in the picture. We take the sutures from the end of the tarsal plate at the point where this pre-septal muscle overrides the pre-tarsal, and then attach it to the skin near the lid margin and tighten it, so it automatically everts the lid. However, it is temporary because as the time goes by, the sutures become loose or get absorbed and the condition may recur. The middle picture is the proper operation of senile entropion. This is known as Weiss procedure. It permanently cures the disease. What do? We make a full thickness horizontal incision in the lid, lower lid mind. In the lower lid, just beneath the level of tarsal plate, as you are seeing the yellow tarsal plate here, incision is made in full thickness of the lid, and then two things are done. The lower lid retractors, as you see here, they are taken in the suture and they are pulled and to be attached to the anterior portion of the tarsal plate. So the pull that was misdirected posteriorly, that is again directed at its inferior edge to improve the vertical stability. Secondly, once we cut this lid horizontally at this level, and it heals later with the normal healthy fibrous tissue, and that fibrous tissue makes a barrier between pre-septal and pre-tarsal portions of the orbicularis oculi muscle and does not let the pre-septal muscle slip and override on the pre-tarsal muscle by closing the lids, and that cures the disease. So we do two steps in it: to create a healthy fibrous tissue and to alter the pull of the lower lid retractor from posterior to the anterior margin of the tarsal plate of lower eyelid. However, in a very few patients, there still is recurrence, and in those patients we do Jones procedure. Jones procedure is shown in the right portion of this picture. It is actually extension of the Weiss procedure. Here the total shift of lower lid retractor is not only to place or detach it from lower border of the tarsal plate and to attach it onto the anterior surface of the tarsal plate. Not only anterior border of the lower lid tarsal plate, it is attached to the anterior surface of the tarsal plate of the lower lid and permanently pulls it outwards. Rather, in some patients, slight degree of ectropion develops that is required to prevent another recurrence. So there are three procedures to be remembered. Temporary one is transverse lid everting sutures. Then regular procedure is Weiss procedure, And even if recurrence develops in one odd case, then Jones procedure. This is a treatment of senile entropion. Now see the next slide. In this picture, it is number 11. Cicatricial entropion. Cicatricial entropion develops due to fibrosis in the conjunctiva, palpebral conjunctiva. Due to cicatrizing conjunctivitis, their condition they cause conjunctival scarring like trachoma, Stevens-Johnson syndrome, and cicatricial pemphigoid, chemical injuries like acid burns, and lacerating wounds of the conjunctiva. In this next slide, that is slide 12 here, you are seeing on the left picture, there is inversion of the upper lid margin and causing rubbing of the lashes against the cornea. And when we avert this patient as seen in the picture on your right side, the same patient, you see horizontal fibrous white line on the tarsal conjunctiva as a result of chronic conjunctivitis, most commonly due to trachoma. So this fibrous tissue pulls the eyelid margin vertically and inverts it, causing cicatricial entropion. Next slide is showing surgical treatment of this entropion. Treatment is Fox procedure and modified Wheeler procedure, again to reverse or neutralize the normal lid anatomy back to normal. What do? We take a triangular piece of the trussel plate, say a triangular wedge, dissect it, and then join the margins together, and we achieve the result. We have reversed the pull. Now the eyelid becomes normal and cicatricial entropion is over. Its modification is do the same procedure, that is wedge resection of the tarsal plate, as well as apply a flap of the pretarsal orbicular muscle over it. That further stabilizes it and reduces the chances of recurrence. That is known as modified Wheeler procedure. So these are the two procedures for treatment of cicatricial entropion. That is Fox procedure and modified Wheeler procedure. Now the next variety of entropion is spastic entropion. It is due to stress or any other reason the patient is suffering from blepharospasm. Its treatment is inject botulinum toxin in the muscle, and that relieves the spasm for 5 to 6 months. It has to be repeated after that time. Next, now you should know the difference between trichiasis and pseudotrichiasis. The eyelashes rubbing on the eyeball as a result of entropion, they are not misdirected, but eyelid margin is misdirected posteriorly, and this rubbing of the lashes against the conjunctiva and cornea is known as pseudotrichiasis. Whereas in the right side of this picture, slide number 15, the actual entropion, there is no entropion or ectropion, but there is actual or true trichiasis, where eyelashes are misdirected and they are rubbing against the cornea in the presence of normally placed lid margin. That is trichiasis. So you should know the difference between trichiasis and pseudotrichiasis. Trichiasis develops secondary to trachoma, eyelid margin injuries, or chronic ulcerative blepharitis. So this is the summary of the treatment we have discussed. Summary of the treatment of senile entropion, cicatricial entropion, and spastic entropion. Now coming back to the next topic of ectropion. Ectropion is defined as eversion or outward rolling of the eyelid margins. Again, it is of different types. Congenital, that is the baby born with it. Cicatricial is the most common. Then paralytic, senile, and mechanical. We will discuss one by one. This is typical ectropion. As you see, the lower lid is everted out. Cicatricial ectropion. Here, fibrosis is occurring on the skin of the eyelid, whereas in cicatricial entropion, fibrosis was or cicatrization was on the tarsal conjunctiva. Here it is on the skin that contracts and pulls the lid outwards. It can be present due to previous surgery, lacerative wounds, or chemical burns of the skin of the eyelid, or chronic lower lid dermatitis due to chronic epiphora or use of medicines for a long time. This is a typical case of cicatricial ectropion where eyelid is pulled away inferiorly by fibrous tissue of the lid, margin skin. This is a case of paralytic ectropion. The lady is having paralysis of the left facial nerve. As a result, the entire face is drifted towards right because of unopposition of the right-sided muscles of facial expression. Our concern is the eye is open, patient is unable to close the eye. As a result, there is corneal exposure and recurrent corneal ulcers and watering develops. Despite the watering, the actual cornea remains dry because of exposure. You should know the difference between Bell's paralysis and Bell's phenomena. Bell's paralysis is due to paralysis of the facial nerve while passing through the tympanic cavity medial wall, and that due to paralysis of the facial muscles and expression. But Bell's phenomena, very important to know it. It has surgical importance and clinical significance. Once we close the eyes, our cornea rolls up and out, and it is away from exposure. You see in this patient, he has closed both eyes, and we elevated the lid of the left eye, and we see no cornea there because cornea has rolled up and outwards, is under cover of the lid, and that protects it. It is a protective reflex of the eye to prevent it from exposure damage. In this patient, the phenomena is poor. We have asked the patient to close the eyes, and when we elevate the lid of the right eye, the cornea is at its normal place, it is not going up and out. So this patient is more prone to damage of the cornea in case of exposure. So Bell's phenomena is important to prevent any exposure. In case of eyelid, exposure damage to the cornea is prevented. This is a typical case of involutional ectropion. I had shown you earlier it once we were comparing entropion versus ectropion. The lid is a bit everted downwards and forward, and fluorescent dye is placed in the conjunctival sac. You can see clearly the fluorescent dye separating the bulbar conjunctiva from the lid margin. It is graded on the basis of severity. Mild lid laxity is grade 1, which is hardly visible to the naked eye. Then grade 2 are scleral show, there is no punctal eversion. Punctum is at its place, so there is no watering, but there is slight show of the sclera. See in this picture, again in this picture, slide number 24, there is show of the sclera. You can see sclera is visible behind the lower eyelid. This is a grade 2 level of involutional or senile ectropion. Grade 3 is once there is lid laxity as well as punctal eversion, यानी punctum जो होता है वो भी आप थोड़ा सा आपको नजर आता है. Punctum gets everted, and in these patients there is epiphora or watering because now tears are not being drained from the punctum into the normal nasolacrimal duct system, and tears flow out because of punctal eversion. So this is an extension of grade 2. Next is the grade 4, the late one, which is persistent eversion of the lid. As a result of that, there is changes in the conjunctiva, and conjunctiva become metaplastic. Now I will show you in the pictures. Go to slide number 27. Now see, upper left is simple grade 2 Ectropion, that is scleral show. Grade 3, upper left, scleral show as well as the eversion of the punctum. Stage 4, lower both the pictures are stage 4, in which you see regular eversion of the lid as well as changes in the palpebral concava. It is turning reddish, dull in both the eyes of these patients. So grade 4 is the one in which there is permanent eversion of the lid with changes in the tarsal concava, which becomes dull, red, and actually it becomes keratinized. Now how to treat senile ectropion? See in the next pictures. This left picture shows treatment of grade 2 and grade 3 rather. Grade 1 and 2 are not actually need surgical repair because grade 1 is hardly visible, grade 2 is showing slight scleral show, but there is no eversion of the this punctum, so there is no excess watering, the things remain normal. But grade 3, here there is lid eversion in addition to eversion of the punctum, so there is permanent watering and the patient is exposed to dry eye. Water comes out, is not proper all the time watering, and still the cornea, upper portion of the cornea remains dry. So what we do is medial conjunctivoplasty. As you see in the upper part of the picture, we make a diamond shaped incision on the tarsal conjunctiva just behind the punctum, and then excise this tarsal conjunctival tissue and suture this wound in horizontal direction. That pulls the punctum inwards and relieves the symptoms of watering in the patient. But if it is severe enough as in the lower portion, then lazy T operation is done, in which apart from this surgery, we make a triangular excision of the lid so that its base is towards the eyelid margin, and then suture it relieves the horizontal lid stability and the things come to normal. It is better shown on the right side of the picture, that is modified Cohen-Zavanovsky technique, in which a pentagon of the whole lid is excised and then the rest of the tarsal plate and the lid is sutured, and the flap of the muscle, that is orbicularis muscle, and additional tissue is excised and is superimposed upon this excised tarsal plate to retain the healthy tissue onwards. This is another modification of grade 4 senile ectropion surgery. In case of paralytic ectropion, things don't relieve with the above surgical measure, so lateral tarsal slip operation is done, in which you see, just focus on the picture A, E and F. What we do, we take the say 1/3 piece of lateral portion of the tarsal plate of lower eyelid, excise that tarsal plate, then remaining tarsal plate is attached to the lateral orbital margin as seen in picture number F, and this reduces the horizontal lid margin, and that remaining lid becomes tightly or snugly fit to the tarsal conjunctiva, and the problem of ectropion is relieved. So this is done for paralytic ectropion, lateral tarsal slip LTS operation. Some people develop cicatricial ectropion. What is cicatricial ectropion? There is fibrosis of the skin of the lower eyelid or upper eyelid, mostly it is lower eyelid, that contracts and pulls the lid margin out and causes ectropion. Due to reasons I have told you, that Stevens-Johnson syndrome or burns or pemphigoid, etc. In it, we dissect the skin from the underlying tissue, and if the scar is removable, excise the scar, remove it, and then place back the skin as shown in picture B of this diagram. However, if skin is also scarred and cannot take its normal position here, we remove all the scar tissue as well as this scarred skin and then the area is covered by a healthy skin graft generally taken from the back of earlobe, and that graft is healthy and hairless, and that maintains the normal integrity of the tissue, and ectropion is reversed. That was all about the lecture, and thank you very much for the patient listening. Now I will send you an assignment that you will send back to the number mentioned here. This is the number of my PA. What's the number? Send your assignment with answers back to this number, and that will also mark your presence. Thank you. See you next time on next Monday. उमर हो गया ये भी कंप्लीट. अब इसको आपने अब इसको हो गया, अब इसका क्या हो गया?